Now we proceed with our next distinguished guest speaker, Professor Raúl Gazmuri, Professor of Medicine, Professor of Physiology and Basic Sciences, have been taking part of, for a long time, developing resuscitation guidelines, reviewing resuscitation guidelines, and updating them according with the American Heart Association. And just a quick reminder again, please switch your mobiles to silent while here. Thank you very much.
Use that one. Okay. Thank you so much. Thank you so much. This is my first time in the Middle East and in Kuwait, and I want to thank you, the organizer of this event. So far has been wonderful. I have learned a lot from the other speakers. And the topic I'm going to discuss today is more practical. I'm an intensivist. I do some research, but I spend time at the bedside taking care of patients. So I want to give you sort of an overall approach to a patient who is in circulatory shock that we see at the bedside. So the first question that I want to ask or attempt to address is, what do we mean with circulatory shock? And the definition I want to offer you is of a clinical syndrome that results from a sustained failure to deliver the oxygen that is needed to meet the metabolic demands of tissues consequent to a macro or micro circulatory abnormalities. And I want to emphasize the importance of being in a clinical syndrome because people who are taking care of patients have a responsibility to identify that condition, and the nurses plays a very important role in the diagnosis. It's important to realize that it's not a transient event, but it's something that lasts in time, and that the core of the syndrome is the inability of the oxygen to meet the metabolic demands of the tissues. And again, we will see that we have different mechanisms by which a patient develops circulatory shock, and continued on the mechanism, the treatment is going to vary significantly. So what is at the core of this clinical syndrome? And it's oxygen. And I wanted to just go back for a few minutes to the very basic pathophysiology of why oxygen is so important and why oxygen, in a way, drives a lot of the things that we do in critical care. Of course, oxygen is required at the mitochondrial level, and this is for microscopy, electron microscopy of the heart of a rat, showing mitochondria. And if we zoom into one mitochondrium, we're going to recognize some interesting structures here. One is the outer mitochondrial membrane, and the other one is the inner mitochondrial membrane. And in the inner mitochondrial membrane, we have this protein embedded in, which we call it the electron transport complexes, which essentially are proton pumps that pump proton from the matrix to the intermitochondrial membrane to establish a proton gradient that drives this enzyme, the ATP synthase, which is responsible of regenerating ATP from ADP and inorganic phosphate. So the energy that drives these pumps come from nutrients that are metabolized in the Krebs cycle, and the release of electrons and the transport of these electrons allow this process to continue. And what the oxygen does basically takes those electrons away and enable this electron flow to continue forever until we die. So the absence of oxygen essentially is going to clog the system and preclude the proton pumps to build this gradient through which we generate ATP. And when that happens, then glycolysis becomes a very ineffective means to generate ATP through anaerobic metabolism. And what happens is then the glycolysis goes to the end product of lactate. but it's very inefficient. For 1 mole of glucose, through the aerobic metabolism, we generate 32 ATPs, whereas through the anaerobic pathway, only 2. Now, why this is important? Because the lactate diffuses across cell membrane, and we can measure it in the bloodstream. So the lactate is indeed a very good metabolic marker of this inadequate delivery of oxygen or utilization of oxygen, as we have learned throughout today. Now, I wanted to bring to this discussion who was my mentor, Dr. Max Harry Wild, who died in 2011. And he was one of the pioneers of critical care medicine. He was the one who thought that having critically ill patients clustered in one area will help them survive by bringing resources together. He did many things, and one of them was to consider lactate as a marker of the severity of circulatory shock. And indeed, it was him who published many years back in a paper in Circulation in 1970, the famous relationship between survival and the initial lactate when a patient who is critically ill comes to the intensive care unit. And you can see here that in general, if the lactate is less than 3 millimoles per liter, there's a very good probability that that patient who has a clinical syndrome of circulatory shock is going to make it from the ICU. But as the lactate increases at the beginning of the disease process, the probability is less. However, that's not the end of the story. And it depends a lot of our action and how effective we are in managing this situation and bringing the lactate down. And this is a study that was published more recently by Dr. Marty in 2013. And what he showed was that even if the lactate was high at the beginning of this disease process, if the lactate came down, there was a good probability that the patient was going to survive and go home. Whereas if we failed to bring the lactate down, it means that we're failing to reverse circulatory shock, and the probability of survival is much, much less. So we do have, among many other things, one simple measure that we can follow at frequent intervals, every 2, every 3 hours, that will tell us whether or not our patient is improving. Now, I wanted to go very briefly through this basic equation that tells you where we can act in order to improve oxygen delivery to the tissues. And probably many of you know this one. I think it's very helpful to remember it and to have it at the bedside. Oxygen delivery is where we're going to act. And oxygen delivery is a function of the cardiac output, as we have discussed repeatedly today, and the arterial oxygen content. The number 10 is there only to adjust for the units of measurement. Now, if we concentrate on the cardiac output, this is a function of the heart rate and the stroke volume. And the stroke volume turn depends on the ejection fraction, which is going to be affected by the stroke volume is going to be a function of the ejection fraction times the end diastolic volume. The end diastolic volume is a variable that we can optimize by improving the preload. And that's one of the reasons why we give fluids to a patient who is in circulatory shock. We want to increase the preload, increase the end diastolic volume, and for the given ejection fraction, we are going to end with a higher stroke volume, and therefore with cardiac output. That's a very simple reason. We also are mindful that contractility might be affected, as we learned today. In patients with sepsis, contractility might be compromised, and for that, we might want to use an inotropic agent. And a heart that has low contractility is also more susceptible to increases in afterload. So all those are parameters that impact the management that we can assess at the bedside and decide what is the best course of action. And in terms of oxygen, it's important to realize that when we look at the arterial oxygen content, it's a function essentially of 2 main factors. One is the hemoglobin that we can measure, of course, and the other one is the oxygen saturation, whereas the partial pressure of oxygen plays a very little role in terms of oxygen being transported, dissolved, is minimal. That's the reason why measuring the pulse oximetry is sufficient. We don't need to measure the partial pressure of oxygen in the blood gas all the time. And with those two numbers, we will estimate whether or not our arterial oxygen content is adequate. So in going back to the beginning, these are the parameters that will influence our oxygen delivery. And those are the ones in which we're going to act. Now, going back to history a little bit also, I think it's important to discuss the contribution of Dr. Jeremy Swan and Dr. William Gans, the ones who conceived the concept of the Swan-Gans catheter. And at some point, this was a device that we use a lot at the bedside. Today, because we have many other means to assess the hemodynamics, including ultrasound, echocardiography, we rely less and less in the Swan-Gans catheter. But it's important to recognize that because of this device, this catheter, early on with Dr. Wild and others, were able to describe different types of circulatory shocks. And essentially, we recognize 4 forms. One is hypovolemic, in which the cardiac output or the cardiac index is reduced because there is less intravascular volume, like in hemorrhagic shock. And you're going to find with the Swan-Gans catheter that all the pressures are low. The pulmonary artery occlusive pressure, the pulmonary artery pressure, and the right atrial pressure. We also recognize obstructive shock, in which something opposes mechanically to blood flow, and a perfect example would be a massive pulmonary embolism in which the cardiac index is reduced, but the pulmonary artery occlusive pressure, which reflects what happened to the preload of the left ventricle, is not increased, and it might be reduced, whereas the pulmonary artery pressure, because of the obstruction, is increased, and the right atrial pressure as well. Cardiogenic, in this case, an acute myocardial infarction. Again, the cardiac index is reduced because of inadequate left ventricular function, and all the pressure upstream are going to be elevated. And then we have this weird thing, but we call it distributive shock, whose representative, the most common one, is septic shock. And anything can be there. Early on, if we don't treat a patient in septic shock, that patient may have a component of deficit of intravascular volume and may actually present as hypovolemic shock. As we treat the patient typically and we improve after the preload, the patient moves into the hyperdynamic state. What I wanted to emphasize is that the first 3 ones have in common that the core problem is a reduction in cardiac output. And the tissues are, at the beginning of the process, relatively intact. And our purpose in treatment is to improve the cardiac output. When we look at septic shock, it's a very difficult process. And dealing with that requires a different approach. And we can discuss that, although that's not the main purpose of this presentation. So how do we assess adequacy of perfusion? I want to emphasize the importance of the repetitive bedside assessment by nurses, because if somebody has a reduction in cardiac output, the physiological response is to have an increase in peripheral vascular resistance, and that gives clinical signs that can be easily recognized at the bedside. Decreased skin temperature, reduction in capillary refill. There will be a reduction in urine output. So it's very important from that perspective to recognize and alert the team the patient is suffering a state of inadequate perfusion. Very important is to assess the preload. And we can discuss at length how important is this. On the one hand, we want to optimize the preload so that the left ventricle is going to work well as the right ventricle. On the other hand, because the treatment of the preload is to give fluids, we want to avoid excessive amount of fluid that will result in edema. So I like to use the concept of optimizing the preload in a patient who is in circulatory shock. And it's very likely that every single state will need some amount of fluid. Now, the specific amount is patient-dependent. So I'm not very much in favor of a fixed amount of fluid, even though that is what is being recommended. I like the idea of titrating the amount of fluid in a given patient. And from that perspective, we have made progress by looking at non-invasive technique. And essentially, I'm going to skip through these two slides and skip to what I believe to be very important, which is the use of ultrasound at the bedside. It's okay to look at the jugular veins and you can get a lot of information, but I find very useful and not difficult to learn to concentrate on the IVC with bedside ultrasound, with the purpose of increasing the stroke volume and therefore the cardiac output. So here, for example, I don't think I can run the... So here's a case, for example, of a patient who was intravascular volume depleted. And the IVC was very collapsed, and especially more during inspiration. It will collapse close to 67%. This is a situation which identified a fluid responsiveness condition. This is a different situation in which the diameter of IVC is normal, with minimal collapse during inspiration. This patient is not likely to improve with fluid. So the fluid, right now, we have means to titrate and optimize. Now, what about vasopressors? We don't have time to discuss, but I can tell you that we may have a different perspective from my distinguished colleagues. From a clinical perspective, what I see more often is that once the vasopressor is initiated, the team tend to relax and allow the titration of the vasopressor to a target mean aortic pressure. Now, I'm not sure that that's the best way. I think we need to reassess the patient frequently. And it is something that is controversial, but I throw this here just for discussion. I look at the Sepsis 3 document that was published less than a year ago in JAMA. And in Table 3, they look at mortality in relation to 3 conditions: the responsiveness to fluid, the use of a vasopressor agent, and whether or not the lactate was elevated. I rearranged the table, and this is what I found. That when the other conditions are the same, meaning the use of the use of fluid administration, and whether or not the patient remains hypotensive after the fluid, for the same level of lactate, if the patient was on a vasopressor, for the entire group, mortality was worse. Now, I'm not saying that this is cause and effect, but I think this data should give us some pause and ask the question as to whether or not we have to use vasopressor to the level that we use. Now, to finalize my talk, this is what we do in our intensive care unit. We believe in the concept of reassessing the patient frequently. You have 4 conditions here that can lead to circulatory shock: hypovolemic, cardiogenic, obstructive, and distributive. And very often, we have a combination of all of them. And the goal is to stabilize the patient. How we define hemodynamic instability, clinical signs, hemodynamic signs, and elevation in lactate, and if the patient, for whatever reason, is receiving a vasoconstrictive agent. At that point, we need to assess, come up with a plan, institute the plan, and not leave the patient alone. Come back. How often? I don't know. I will say at a minimum 3 hours later. Do exactly the same. In a way, like we do, we run a code. We will check the pulse every 2 minutes. Let's do the same thing for a patient who is in circulatory shock, without forgetting that we have to reassess constantly the underlying condition and don't leave that alone. So that's my last slide, and this is where I come from, an institution that has a university on one side and a hospital that's a combination with a VA hospital for retired military personnel, and active duty. All together, we work there. Thank you.
Thank you.